Greetings from IJA. I, Dr. Kiran Mahendru, will present an original article from the December issue. It is a randomized control study on pericapsular nerve group block versus supra-inguinal fascia iliaca block for functional outcome in patients undergoing hip surgeries. Until recently, hip surgeries focused on surgical fixation and perioperative pain management with limited emphasis on postoperative functional recovery. Now, modern care integrates ERAS protocols, emphasizing on pain relief, early ambulation, and rehabilitation after surgery, aiming to improve the functional outcomes. This approach facilitates the early discharge and reduces the risk of postoperative complications like DVT, pneumonia, surgical wound infections, pressure sores, and delirium, which can result from prolonged immobility of the patient. The National Institute for Health and Care Excellence guidelines also recommend initiating mobilization the day following surgery unless there is any medical or surgical reasons to avoid it. Among the regional anesthesia techniques used in hip surgeries, the pericapsular nerve group block and the fascia iliaca compartment block are two commonly employed methods. The PENG block in particular supports the ERAS goals and reduce the opioid use and facilitates early mobilization following the hip surgeries. Now, the primary objective of this study was to compare the quadriceps muscle strength grades between the groups receiving the PENG block versus supra-inguinal fascia iliaca block at 24 and 48 hours post-surgery. The secondary objectives were to compare the weight-bearing capacity at 24 and 48 hours post-surgery, assessment of the VAS scores at 24 hours at rest, total opioid consumption over the 24 hours, and the duration of analgesia between the two groups. The hypothesis of this study was that PENG block will provide superior post-op functional outcomes due to its reduced motor blockade effect compared to the supra-inguinal fascia iliaca block, allowing early mobilization and recovery. The study was registered with the CTRI. It is a randomized double-blind controlled trial conducted from May 2023 to April 2024 and included patients 60 adult patients of ASA physical status 1 to 3 undergoing hip fracture surgeries, including dynamic hip screw fixation, proximal femur nailing, and hemiarthroplasty under subarachnoid block. The patients excluded from the study were the presence of infections at the block site, presence of any coagulopathy, contraindications to local anesthetics, inability of the patient to understand the VAS scores, diabetic neuropathy, or neurological deficits in the lower limb. The randomization was done using computer-generated sequence of random numbers, and the allocation concealment was maintained using sequentially numbered opaque sealed envelopes. The study participants were blinded to their group allocation, and a blinded observer assessed the postoperative functional mobility, pain scores, 24-hour opioid consumption, and duration of analgesia. During the preoperative assessment, patients were educated on the use of VAS scale, and preoperative VAS scores at rest were recorded. Subarachnoid block was administered with 25 micrograms of fentanyl and 14 to 16 mg of 0.5% heavy hyperbaric bupivacaine using a 26-gauge Quincke spinal needle, followed by application of assigned ultrasound-guided block. The group P received the PENG block using 30 ml of 0.2% bupivacaine mixed with 4 mg of dexamethasone. A low-frequency curvilinear probe was placed over the anterior superior iliac spine, followed by transversely over the anterior inferior iliac spine, and then rotated 45 degrees counterclockwise to align with the pubic ramus. The iliopubic remnants, the iliopsoas muscle and tendon, femoral artery, and pectineus muscle were visualized. A 21-gauge 100 mm stimuplex needle was inserted from lateral to medial side using an in-plane approach to place its tip between the psoas tendon and the pubic ramus. And then the study drug, which was 30 ml of 0.2% bupivacaine with 4 mg dexamethasone, was injected. The group S received ultrasound-guided supra-inguinal fascia iliaca block with the same anesthetic mixture using a high-frequency linear probe in supine position. The anterior superior iliac spine was palpated and the femoral artery was identified at the inguinal crease. The sartorius muscle was traced Kepler to the ASIS insertion, revealing the iliacus muscle. The transducer was then rotated towards the umbilicus to view the anatomy from superficial to the deep. And the 21 gauge needle was advanced to pierce the fascia iliaca, and the drug was injected into the fascia, iliaca, and iliacus muscle, ensuring chordomedial spread towards the femoral nerve. The standard analgesic regimen was followed in the post-operative period, including IV paracetamol 1 gram every 8 hours unless contraindicated. IV tramadol 50 to 100 mg was used as rescue analgesic whenever the VAS score was more than equal to 4 to a maximum of 400 mg in 24 hours. Following which, if the VAS was still more than equal to 4, another rescue opioid, that is IV fentanyl, in the dose of 1 microgram per kg was used as slow IV bolus was given to the patient. The outcomes measured were the quadriceps muscle strength, which was assessed at 24 and 48 hours post-surgery using the Oxford Muscle Strength Scale, where the patient was positioned supine with the hip flexed at 45 degrees and knee completely flexed, and the patient was asked to extend the knee. Strength was rated from 0 with no muscle contraction to 5 with full range of motion against resistance and gravity. Weight bearing was assessed at 24 hours using maximum weight bearing graded as either no weight bearing, which was grade 1, where the leg did not touch the floor at all, or toe touching weight bearing, which was grade 2, where the foot may touch the floor only to maintain balance without weight bearing, whichever maximum the patient was able to perform. At 48 hours, maximum weight bearing was graded as either partial weight bearing, which was grade 3, where up to 40% of body weight was supported, weight bearing as tolerated, which was grade 4, that is the weight chosen independently by the patient, or full weight bearing, that is grade 5, supporting 100% of the body weight, permitting normal walking. VAS pain scores were assessed at 24 hours post-surgery at rest. Total opioid consumption over 24 hours was noted, and the duration of analgesia, defined as the time in minutes from administering the block to the first requirement of the rescue opioid analgesic at a VAS score more than equal to 4. The sample size for 95% confidence level and 95% power was calculated to be 29 patients per group, and this number was rounded to 30 per group, yielding a total sample size of 60 patients. SPSS 21 was used for statistical analysis using students' t-test, Mann-Whitney U test, and chi-square test. This is the consort chart showing that 60 patients were assessed for eligibility and 60 were randomized into 30 in each group, that is group P and group S. Now, this table reveals the demographic and other variables which were comparable in both the groups, and the variables assessed were the age, gender, BMI, ASA physical status, the duration of surgery in minutes, and the baseline VAS scores. Now, coming to the primary outcome of the study, which was the quadriceps muscle strength at 24 hours and 48 hours. As can be seen, the quadriceps muscle strength grades were higher in the group P than group S, and this was statistically significant difference. Now can be seen that weight bearing grades at 24 hours were also higher in group P as compared to group S and was statistically significant result. Whereas the weight bearing grades at 48 hours were equivalent in both the groups. VAS scores at 24 hours post-operative period at rest were lower in group P as compared to group S. Total amount of opioid analgesics used over the 24 hours period was also statistically significantly lower used in the group P as compared to group S. And the total duration of analgesia of comparing the two blocks was also higher in group P than in group S. So in this study, the mean quadriceps muscle strength grades between the two groups were significantly higher in group P compared to group S at 24 and 48 hours postoperatively. Comparing the weight-bearing capacity between the two groups can be considered as an indirect indicator of the motor sparing effect of the blocks, attributed either to the motor sparing effect of the PENG block or possibly to its superficial analgesic efficacy compared to the supra-inguinal fascia iliaca block. Now, the reduced VAS scores observed at 24 hours post-surgery in the PENG group further support this finding, which might have facilitated easier muscle movement and improved weight bearing post-operatively in patients who received PENG block versus those who received supra-inguinal fascia iliaca block. Weight bearing grades were statistically insignificant at 48 hours postoperatively, and this was possibly owing to the duration of analgesia provided by these blocks, which is typically up to 24 hours. This suggests that PENG block may promote early ambulation and motor functional recovery, potentially lowering the risk of complications like DVT, pulmonary issues, pressure ulcers, and delayed discharge. The authors used 0.2% ropivacaine as it has lower incidence of motor blockade secondary to a greater degree of motor sensory differentiation, thereby further supporting early mobilization and safety in the postoperative period. The cadaveric studies also revealed that 20 ml of dye effectively dispersed within the anterior hip capsule, while 30 ml volume extended to ilius vas, vastus intermedius, and gluteus medius, as well as near the femoral nerve, potentially impacting the quadriceps muscle strength. In this study, authors administered 30 ml of 0.2% ropivacaine for both the blocks to examine the potential motor blockade associated with this drug volume and its sensory effects. The limitations of this study are various types of surgeries performed by different surgeons, leading to variations in the surgical approach, tissue handling, and operative time, which could have influenced the intensity of pain among the subjects. Lack of objective means of assessment of the motor function, like using devices like dynamometer to evaluate whether PENG block is truly motor sparing block. They also suggest that further research is needed to evaluate the maximum weight bearing capacity possible in patients undergoing hip surgeries with these blocks. Therefore, to conclude, the PENG block may offer improved postoperative functional outcomes, including enhanced quadriceps muscle strength and weight bearing capacity. Compared to the supra-inguinal fascia iliaca block, it facilitates early ambulation and hospital discharge and provides superior postoperative pain control for patients undergoing hip surgeries. Thank you.